classes for the postgraduate students, we find that whenever we go as an examiner for the postgraduate exams, our students do very well with recent advances, etc. But where the basics come, they really falter. And today evening, we have a great teacher of teachers, Dr. Sunita Malik with us, who is going to teach the basics of our obs and gynae, the basic regarding the pelvic anatomy, as well as the dummy pelvis. Madam is teacher of teachers, as I told you. She is very passionate about teaching. She is professor at ESIC Medical College and Hospital, Faridabad. She had been former professor and unit head Obs and Gynae, VMCC, as well as Safdarjung Hospital, New Delhi. She has been chairperson Gynae Oncology Committee of AOGD, chairperson Breast Cancer Awareness Committee of AOGD. Madam has been vice president AOGD, secretary AOGD, joint secretary NARCHI. Madam has many publications in national and international journals. And as I told you, she is very passionate about teaching. And I'm sure all the students will highly benefit from her teaching. And you can have an interactive session at the end of a class. You have any doubts, you can ask Madam. Madam is very approachable and she will definitely clear all your doubts. Over to you, Madam, for your class, ma'am.
Thank you, Dr. Mala, for your kind introduction. I will start. I will just share my screen. Just a second. Can you see my screen?
Yes, ma'am.
Full view?
Not full view.
But again, I don't know why this happened. I'll have to again reshare. Sorry. Yeah, now is it visible? Full view? Hello?
Yes, ma'am, it is visible.
Yes, ma'am.
But once I put it in full view, I don't know why my slide stopped moving. That's the problem.
Ma'am, it is also visible. You can start this mode also.
Okay, I'll just enlarge it if I can do that. This one. Okay, so today my topic is fetal skull and maternal pelvis. You must have seen this skull many times. Basically, it has let's discuss first the areas of skull. It has got vertex, brow, and face. Vertex is a quadrangular area bounded anteriorly by bregma and posteriorly and the coronal sutures. Can you see my hands also along with that on the skull?
Yes, ma'am, it's showing.
Yeah, okay. So, so this is the bregma and this is the coronal suture, and behind by lambda and the lambdoid suture, and laterally a line passing through the parietal eminences. So this quadrangular area is the vertex of present. That's what presents in the vertex presentation. Then there are area that's known as brow. Brow is bounded on one side by the anterior fontanella and the coronal suture, and on the other side by the root of the nose. So this area between the interior fontanelle and the root of the nose, and on the sides are the supraorbital regions on the either side. So this area is bro. And now the next is the face. In the face, we have again root of the nose
I'm
and the
sorry,
supraorbital ridges.
I'm sorry, it's not visible right. Can you do your screen little bit down now?
Okay. And this one.
Yes, ma'am. It is right. It is good now.
Okay. So the face is starting from the root of the nose, the supraorbital reaches, and by the junction of the mouth and the neck. That's what it is. So this is face. I'll just show you in the pictures also. And now before that, coming on to the denominator. By definition, denominator is the lowermost point which can be felt on per abdomen and per vaginal examination. So in the bro presentation, it is the sinciput, and in the vertex presentation, it is the occiput behind. Okay. So this is what it is. Now starting from the root of nose till the submentum region is the face. Again, root of nose till the interior fontanella is the bro. From the interior fontanella till the posterior fontanella. This is vertex area and this is quadrangular area between the two. And the denominator is occiput in this and sinciput in this. Okay. So coming on to next. This is again to show you end on view. These are the two parietal eminences. So from on the sides, this area between the two is the in a fully flexed head. This is the area which is going to present. Now coming on to the sutures, the sagittal suture is between the two parietal bones. Coronal suture is between parallel and on the parental bones. So this is coronal suture, parietal and the frontal bone. And the frontal suture is between the two frontal bones, and lambdoid suture is which separates the occiput. This is the lambdoid, which separates occiput from the parietal bones. So coming again, this lambdoid suture, sagittal suture between the two parietal bones, and the coronal suture. So these sutures, they are the obstetric importance is that they permit gliding movement of one bone over the other during the molding of the head. And we can palpate the sagittal suture, which gives us an idea of the manner of engagement of head. That how it is engaged, whether it has crossed the pelvic rim or not. But generally, when it engages, it doesn't engage straight like this. It either engages in anterior syncretism or posterior syncretism with some degree and rotation. So then otherwise, in a fully flexed vertex, it is the biparietal diameter which is going to present. But once, if there is some asyncretism, then it's subparietal and supraparietal. So this is the one which is going to present, which is the smaller in diameter, 8.5 centimeter. Biparietal is 9.5 centimeter. The super and subparietal diameter is 8.5 centimeter. If this is some asyncretism, the smaller diameter present, as it descends, fully engages, the full diameter will go into the pelvis. Now coming on to the fontanelle, it is the white gap in the suture line, which we have already seen in the picture. Anterior fontanelle. This is which is between frontal bones anteriorly, sagittal, the coronal suture, the sagittal suture, and the frontal suture. So this is the quadrangular area on either side. So it's a diamond shape. Okay. And the anterior-posterior and transverse diameter is approximately 3 centimeter each, and it remains open till 18 months after birth. So it allows the growth of the brain even after the birth. So this suture is very important. And it also denotes the degree of flexion of head. So once the head is presenting, so if it's fully flexed head, you will be feeling this anterior suture, this anterior fontanella high up, and the lambdoid suture should be lower down, the occiput bone. But if it is deflect, then you can feel this better. So that's why this will tell you whether if you can feel this anterior fontanella, then chances are it's little deflexed. Its palpation of the floor after the birth depicts the intracranial status. It is depressed in dehydration and elevated in increased intracranial tension. Collection of blood and exchange transfusion can be done via the superior longitudinal sinus. And CS can also be drawn through the angle of the anterior fontanella, although we don't do it, but really if it has to be done, it is there. Now coming on to the posterior fontanella. Posterior fontanella is 3 suture lines, sagittal suture anteriorly, lambdoid suture on either side. It's triangular in shape. 1.1, 1.2 into 1.2 centimeters. Again, floor is membranous, but it becomes bony at term. So at the time of the birth, it's already ossified. There's some small sagittal fontanella also, which is present on the sagittal suture at the junction of anterior 2/3 and posterior 1/3, but it doesn't have any clinical importance. Now coming on to the diameters. So in a flexed vertex, fully flexed vertex, we have suboccipitobregmatic. So this is the occiput and the suboccipitobregmatic till the bregma, 9.5 centimeter, and biparietal diameters on the other side. So that's the vertex. While in bro, we have mentovertical, starting from the chin till the top of the vertex. That's 14 centimeters, a fully deflexed head, partially extended also. So that's what the bro is. And in the face, we have sub from the submentum till the again bregma. It's again 9.5 centimeter. Then if the vertex is not fully flexed, instead of having suboccipitobregmatic, we'll have occipitofrontal, which again becomes 11.5 centimeters. So this is the area deflexed head. This area will present. So that's what you should be careful which area is present. It's fully flexed, 9.5 centimeter, deflexed will be occipitofrontal, from occiput to the frontal. That's what the area will be. So coming on to the diameters, how much is it? Suboccipitobregmatic, I had already told, from the nape of neck to the center of the bregma, it's 9.5 centimeter, present in fully flexed vertex. Suboccipitofrontal, from the nape of the neck to the anterior end of the anterior fontanella or center of the sinciput, that's 10 centimeter, which is in incomplete flexion of the vertex. Occipitofrontal is just shown you from the occipital laminus to the root of the nose, 11.5 centimeter. That means marked deflection. After that, further extension occurs. Then comes the bro, mentovertical, 14 centimeter, 13.5 centimeter. And when it's fully extended, then it is face submentopragmatic, 9.5 centimeter. But some it's incomplete extension, like in incomplete flexion, we have 11.5 centimeter face. So now you can see only 9.5 centimeter if it's fully flexed or fully extended can deliver. Otherwise, it's going to be a problem, because as we are coming to the pelvic diameters, because the lowest pelvic diameter is 10 to 10.5 centimeter, and we have to allow for the soft tissue also over that. So it's going to cause a problem. So these diameters you should be remembering, and which position it is there. Okay. Now coming to those were all epidiameters. Now coming to the Transverse diameters of the skull. We have biparietal diameter, 9.5 centimeter between the true parietal eminences. Super, which I already told, the little asyncretism is there, and supraparietal and subparietal, 8.5 centimeter. And the bitemporal diameter between the two temporal bones here. So that is 8 centimeters between the inferior ends of the coronal suture, and bimastoid diameter is 7.5 centimeter distance between the two mastoid processes, which is incompressible. This is very important. If any pelvis is asymmetrical or too much contracted, and that it cannot even accommodate 7.5 centimeters, then we can't even think of doing destructive operations. So that's this diameter importance is bitemporal and bimastoid diameters. So it all depends if contracted pelvis. If these are there, then don't even think of doing any destructive operation, even in a dead baby. Okay. Now coming on to the circumference, complete flexion, biparietal, suboccipital, pragmatic shape, almost round, 275 centimeters. Sorry, 27.5 centimeters. In deflex head, biparietal, occipital, biparietal on one side, occipitofrontal on the other side, oval in shape, 34 centimeter. Incomplete extension, that is biparietal mentovertical, 37.5 centimeters. And biparietal, complete extension, biparietal on one side, submentopragmatic is 27.5 centimeters. Now you know we have three diameters which are 9.5 centimeters: suboccipitopragmatic, submentopragmatic, and biparietal diameter, which are 9.5 centimeters, which are in full extension and full flexion. Okay, so this was about the fetal skull. Now coming on to the maternal pelvis. Maternal pelvis, it is composed of two innominate bones, one sacrum and one coccyx. Okay, so innominate bones are formed by the ilium, the ischial bone, and the pubic bone. So these three together are fused together. They are known as innominate bones, and the sacrum and the coccyx. Now, there are four joints, two sacral-like joints on both sides, sacrococcygeal joint between the sacrum and the coccyx, and symphysis pubis. So these are the joints which are there in this sacrum. It can be divided into false pelvis and true pelvis. The area above the inlet is false pelvis, and the area below is the true pelvis. So this is the brim of the pelvis. It starts from the upper border of symphysis pubis, pubic crest, pubic tubercle, pectineal line, iliopubic eminence, iliopectineal line, sacroiliac articulation, and the sacral promontory. So this is the boundary line between the true pelvis and the false pelvis. This is shown here also. So we have this symphysis pubis, pubic bone, pubic tubercle, then this pubic crest and the iliopectineal eminence, iliopectineal line, then the sacroiliac joint, and then the sacral promontory. So this is the boundary of the pelvis. And the area above is false pelvis, area below is true pelvis. We as obstetricians are more worried about the true pelvis through which the fetus has to pass through. Now the joints, we have symphysis pubis. This is a fibro-cartilaginous joint, no capsule. Sacroiliac articulation. So it's a synovial joint with a capsule. Then sacrococcygeal joint is a hinge joint, but it is also synovial joint because these are a little bit mobile. Now the ligaments which join them together in front of the sacrum, we have anterior longitudinal ligaments, coming from the lumbar vertebra, then iliolumbar ligaments, which are joining the lumbar vertebra and the ilium bone, then the interior sacroiliac ligament, lumbosacral ligament, sacrospinous ligament. This is very important between the sacrum and the spine. Ligament, which divides this foramen into two. And then we have inguinal ligament, starting from the anterior superior iliac spine to the pubic tubercle. Then the sacrotuberous ligament down below, and interpubic fibrous cartilage. So these are the ligaments in the pelvis. The false pelvis, the importance of false pelvis, doesn't have any obstetric significance. It is formed by iliac portion of the innominate bones and is limited above, I've already told you, by the iliac crest. Only obstetric function is to support the enlarged uterus during pregnancy. Boundaries posteriorly are the lumbar vertebrae, laterally are the iliac fossa, anteriorly is the interior abdominal wall, soft one. So this is false pelvis above the pelvic brim, pink color, and this is a true pelvis below the pelvic brim. True pelvis is chiefly of concern to the obstetrician as it forms a canal through which the fetus has to pass. It's shallow in front, formed by the symphysis pubis, but deep posterior. See, this part is shallow, but this part is deep, formed by the sacrum and the coccyx. It can be divided into inlet, the cavity, and the outlet. So these are the three parts of true pelvis. The boundaries of the inlet, I've already told you, starting from the symphysis pubis, pubic crest, pubic tubercle, pectineal line, iliopectineal eminence, sacroiliac joint, anterior border of ala of the sacrum, and sacral promontory. The plane. This is very important, which sometimes when we ask the students, they are not able to tell. Now, if normally this in a standing position, the pelvis is never like this. It's little tilted like this. You must have seen. And so if we draw a line from the sacral promontory till the symphysis pubis and a perpendicular to that, that is the plane, and the angle formed is the between the inlet and the so this is the plane and the line drawn in the horizontal, and if we see in between, then it is 55 degree the inclination. Okay, so if just think of it, this is the inclination angle. So if there is a lumbar vertebra is fused with the sacrum, then that forms a promontory. So then it will become a very steep angle, a high inclination pelvis, in which the delivery is going to be difficult. And on the other way around, if this one of the sacral vertebra, the S1, is lumbarized, means it is not, the promontory is here. It becomes a low inclination pelvis, very rare, and it doesn't cause any problem in the delivery. This is what I was talking to you, a plane drawn from the symphysis pubis till the sacral promontory and a horizontal line. And the angle between the two is 55 degrees. Similarly, since the outlet is also like that, that forms when we, sorry, that is a 35 degree angle in the inclination of the pelvis outlet. And there's another line, if we draw a line from the first S1, this one, a line drawn it, then the angle between the sacrum and the inlet is 90 degrees. This is known as sacral angle. Between the first sacral vertebra, if we draw a line, and the brim line, the 90 degrees. So if the sacrum is tilted forwards, a flat sacrum, the angle will change. Then again, it is a problem. So these things are very important when we look for the pelvis. Now the curve of the pelvis, axis of the pelvis. I have already said that since it is like this, axis is when we join the inlet, the mid cavity, and the outlet. So if it will in the inlet it goes like this, downward and backward, then it becomes straight, and then the fetus comes out the forward. So that's the curve is anatomical curve and the obstetrical curve. Anatomical pelvic axis is formed by joining the axis of inlet, cavity, and outlet, uniformly curved with the convexity fitting with the concavity of the sacrum. However, the fetus does not transverse the uniform curve for path. Obstetrical age, it is through this axis that the fetus negotiates the pelvis. It is not uniformly curved. Its direction is first downwards, backwards, up to the level of the downwards, backward, up to the level of the ischial spine, and then the abruptly forward. This is how you can see. From the brim, it goes down and back towards the sacrum, then almost straight, and as soon as it reaches the outlet, it goes up. So that's what the curve carries and the axis of the pelvis is concerned. Now coming on to the diameters, in the, we have the inlet, diameters of inlet. Let's start with that. We have AP diameter, which starts from the sacral promontory midpoint to the symphysis pubis, and it is around 11 centimeters. But it cannot be estimated directly, so we have to have a diagonal conjugate. So in inlet, we have true conjugate, obstetric conjugate, and diagonal conjugate. Obstetric conjugate is because this bone is little on the inside, there's a prominence, so it's lesser than the true conjugate. I'll just show you. So yeah, this is true conjugates, upper border of symphysis pubis to the midpoint of sacral promontory. Obstetric conjugate is the midpoint of the symphysis pubis till the sacral promontory, and diagonal conjugate is from the lower border of the symphysis pubis till the sacral promontory. This is important because when we are assessing the pelvis, we cannot assess the true conjugate and we cannot assess the obstetric conjugate. We call it obstetric because fetus has to finally pass through it. This is the part which touches the fetal skull. So when we do the PV examination, this is the one, diagonal conjugate from the lower border of pelvis. This is what we can measure. Okay. So that's why then we subtract 1.2 centimeter from that to get to the true conjugate, and another 1.2 centimeter, about 2 centimeters from the diagonal conjugate is the obstetric conjugate. So this is the shortest AP diameter of the AP plane of the inlet. 10 to 10.5 centimeters cannot be clinically estimated, so inferred from the diagonal conjugate. Diagonal conjugate is from the lower border of symphysis pubis to the midpoint on the sacral promontory, about 12 centimeters, measured clinically. Okay, now coming on to the transverse diameters. Transverse diameters are between the two farthest points on the pelvic bed over the iliopectineal line. So here to here. So this is the transverse diameter. It's about 13 centimeters. It divides the brim into anterior segment and the posterior segment. So what it is, then next is the oblique diameters. We have two oblique diameters, right and left. Each one extends from one sacral iliac joint to the opposite iliopectineal laminus. And this is about 12 centimeters. Right or left denotes the sacral iliac joint. So from where it starts, it's starting from here till this, then it is right oblique diameter, left oblique diameter. Okay. So this is what it is, from one sacral iliac joint to the iliopectineal laminus, similarly on the other side. These are the two joint oblique diameters. So what we have is AP diameter 11 centimeters, transverse diameter 13 centimeter, and oblique diameter 12 centimeters. And when the engagement is occurring, as fetus always likes to occupy most comfortable position. So most of the times the engagement does not occur in the AP diameter. It occurs either in transverse diameter or one of the oblique diameter. Okay, so like this. So because it's 13 or 12 centimeters. There's another diameter in the inlet, which is the smallest diameter. This is this distance between the sacral promontory and the iliopectineal eminence of the same side. This one was opposite side. This is of the same side. This is known as sacrocortilar diameter, and it represents the space occupied by the biparietal diameter while negotiating the brim. So as it is going like this, the biparietal diameter will be there in this diameter. This is the smallest diameter in the inlet, 9.5 centimeter. Now coming on to the cavity. Cavity is the segment of the pelvis bounded above by the inlet and below by the plane of least dimension. Shape is almost round, plane. It extends from the midpoint of the posterior surface of the symphysis pubis to the junction of second and third vertebra. So this is the point, second and third vertebra and the symphysis pubis. This is the area of the cavity. And this is the roomiest because it's 12 centimeter all around. It's also known as plane of greatest pelvic dimension. So the diameters, I said 12 centimeter all around. From the midpoint on the posterior surface of symphysis pubis to the junction of sacral S2 and S3. And the transverse lies over the soft tissue because as you see, there's nothing in the cavity, there is nothing in the, it's a gap, sacroiliac notch. So soft tissues are only there. So the points which touch the soft tissue over the sacroiliac notch and the obturator foramina, that is the transverse diameter of the mid pelvis, also known as plane of greater dimension. Now coming on to the outlet. In outlet, we have obstetrical outlet, we have anatomical outlet. Well, the obstetrical outlet is bounded above by the plane of least dimension and below by the anatomical outlet. This plane of least dimension or the narrow pelvic plane, why do we call it least dimension? So look at these ischial spines. These are inside. So this here is the area which is the least. Once the fetal skull has crossed it, it reaches the ischial tuberosities, then it becomes wider. So this is the area at this level. This is known as the plane of least dimension, and this is the obstetrical outlet. Okay, from the lower border of symphysis pubis to the tip of the ischial spine, and posteriorly to meet the fifth sacral vertebra. So this is the one, is the plane of least dimension. Above was a greatest dimension. This is the least dimension. The diameters in this is bispinous, 10.5 centimeter. This distance between the two ischial spines. AP is 11 centimeter between the inferior border of symphysis pubis to the tip of the sacrum. And there's another diameter which is generally done in outlet, that's posterior sagittal diameter. Posterior sagittal diameters, if we draw a line between the two ischial spines and see the area between the tip of the sacrum and the midpoint of bispinous diameter. This is the posterior sagittal diameter. Okay, this is around 5 centimeter at this level. And the axis, I've already told you, it's a line perpendicular to the center of the plane. So it becomes, at this level, it becomes almost vertical, and as it will reach little out. So this is what it is. If we take the tip of coccyx to the inferior border of the sacrum, symphysis pubis, This is anatomical outlet. If we take the tip of the sacrum and passing through the ischial spines and then the inferior border of the symphysis pubis, it becomes least dimension or obstetrical outlet. So this is tip of coccyx, ischial tuberosity, and inferior border of the symphysis pubis and the pubic arch. So this area is the one which is anatomical outlet. It's almost diamond shape, bounded in front by the lower border of symphysis pubis, laterally by the ischiopubic rami, ischial tuberosities, sacrotuberous ligament, posteriorly by the tip of the coccyx. Consists of two triangular plane with the common base formed by the line joining the ischial tuberosities. This is anterior segment and the posterior triangle. So that's the diamond shaped anatomical outlet. The diameter at this level is AP 13 centimeter, transverse intertuberous 11 centimeters, and the posterior sagittal. Now see the line, posterior sagittal is a midpoint of the line drawn between the intertuberous diameter and the tip. It becomes more, it's 8.5 centimeter. And if we want to see outside on the woman, we can find out the distance between the sacrococcygeal joint and inferior margin of anus. That's the posterior sagittal diameter. Now, the other part of outlet is subpubic angle. It's formed by the approximation of the two descending pubic rami, normally around 85 degrees. And this is the arch formed by the descending rami on both sides. This is of obstetric importance. It measures 6 centimeter between the two pubic rami at a level of 2 centimeter below the apex of the. So at this level, just 2 centimeter below the symphysis pubis, it's around 6 centimeters. And clinically, we can assess it by the 3 fingers. Like we are doing a PV, so we can assess it by this. So it's this level that the finger comes. Now coming on to the waist space of Morris. Before telling you about waist space of Morris, I'd like to tell you about mid pelvis. So I've already said bounded above by the plane of greatest pelvic dimension and below by the mid pelvic plane, which is from the symphysis pubis, S4 and S5 tip of the sacrum. So depending on the configuration of the wound. Now waist space of Morris. See if we see the pelvis end on from the outlet side, and if we place a rounded ball between the two pubic bones, the arch, which is a same diameter as the head is there, 9.4 centimeter, which is coming out at this level. There is always a space between the vertex and the symphysis pubis. And this is in a gynecoid pelvis, it should not be more than 1 centimeter. But if it's an android pelvis, which is conical in shape, this space becomes more. So what will happen? The head cannot go all the way through the, cannot come out all the way through the outlet. It goes more posteriorly. So that's that's why it gets either stuck because this space is more than 1.5 centimeter. Overall diameter is the same. From the tip till this is the same. So if this becomes narrow, the head cannot negotiate out. So that's the problem. So if this waist space of Morris we calculate between the symphysis pubis and the head. It should never be more than 1 centimeter. No, the plane of least dimensions, transverse diameter between the two spines is 10.5 centimeters. AP diameter is 11.5 centimeters from the lower border of symphysis pubis to the point on the sacrum at which the mid pelvic plane meets. And posterior sagittal diameter at the level of ischial spines is 4.5 centimeters. So these are all the diameter which you are supposed to remember. In a way, inlet and outlet are almost different. So inlet is, if we just take anatomical inlet, 11 centimeter AP, oblique is 12 centimeter, transverse is 13 centimeters. And outlet is, AP is 13, and the intertuberous diameter is 11. So that's why, when the fetus has to come out, when it engages in transverse diameter, because AP diameter of inlet is more. Sorry, transverse diameter of inlet is more. But as it reaches the ischial spines, it starts rotating. And because the AP diameter of outlet is more, so from transverse it has to internal rotation, and or from oblique till at the level of ischial spine, and then it will come out. Okay, so the baby delivers by in the AP diameter. The fetal skull and the pelvis, they are in the same direction. So that's important. Significance of this plane of least dimension is, it is the narrowest plane of the pelvis. It corresponds to the origin of levator ani muscle. So because of these muscles, the internal rotation of fetal head occurs at the ischial spines. If some arrest, deep transverse arrest occurs, then it also occurs at the level of this least pelvic dimensions. It is also a beginning of forward curve of the pelvis. It's also a landmark for pudendal nerve block. We feel for the ischial spine, and the nerve process across it, and then we put a block there. Zero station of pelvis is also at the ischial spines, and irregularly overnotched on each side by the ischial spine. The pelvis becomes narrow because of those pointing ischial spines. Now coming on to the types of pelvis according to the shape, we have 4 types of pelvis: gynecoid, anthropoid, android, and platyploid. Okay. Yeah, this is the inlet is round, shape is round. Anthropoid is the shape of the inlet is an AP oval. Android is triangular or a heart shape, and platyploid is transversely oval. So if it is round, the anterior and posterior segments are going to be equal. While in anthropoid also, since it's AP oval, so little narrowing in the interior side, but the segments are almost equal. But in android, posterior segment is short and anterior segment is narrow. In platyploid, both are small. Sacral angle is more than 90 degree in gynecoid, anthropoid, but less than 90 degree in android, and more than 90 degree when it is inclined posteriorly in platyploid. So this is what the shape is of the inlet. Gynecoid round, platyploid transversely oval, anthropoid is AP oval, and android is triangular or the heart shape. The diameters transverse in gynecoid, it is transverse 13 centimeter or 13.5 centimeter, while it becomes less than, since it's smaller, less than 12 centimeters. Anthropoid also AP oval, less than 12 centimeter. Platyploid is a transversely oval, it's high, again as good as gynecoid pelvis. AP diameter is 11 in gynecoid and android, but more than 12 since it's AP oval, it's 12, and in this it is 10. So AP diameter is less. Fore pelvis is wide, narrow, beaked, straight, and divergent. This is what you can see. There's the pelvis, fore pelvis, and now see the walls, straight, parallel. In anthropoid, little divergent, or it may be straight also, but in android it is conical, and platyploid it is divergent. In cavity, straight and side walls are straight and pelvic, convergent, straight and wide. Sacrosciatic notch is wide in gynecoid as well as Anthropoid, while narrow in android and short in platyploid. Ischial spines are prominent only in android pelvis because it's a conical one. Outlet is narrow in android, medium in anthropoid, wide in gynecoid. Diameters are also according less than 10 centimeter in android and more than 10.5 centimeter in platyploid. So these are the planes which we can see. Okay. Which I've already talked to you: inlet, midplane, and outlet. 3 planes. Now coming on to the pelvic assessment. How do we assess the pelvis? This is very important. Clinical pelvimetry, X-ray pelvimetry, ultrasound. Ultrasound tells you more about the fetal skull and the fetal diameters, and MRI. See, these are the 4 ways by which we can do the pelvic assessment. And most of the times, as you also must have done, we do the clinical pelvimetry. The basic principle of clinical pelvimetry is that patient should be comfortable, relaxed, informed consent to be taken, and you should put your fingers. First thing is you should be knowing the dimensions of your hand. The bigger hand will reach the sacral promontory and the smaller hand will never reach. So you should be knowing how much is the distance between your tip of middle finger and the joint. This. So that roughly you know your diagonal conjugate. If it is smaller, contracted pelvis, not otherwise. Okay. The other thing is, once you've introduced the finger, please don't take it out. एक बारी inlet देखेंगे, फिर cavity देखेंगे, फिर outlet देखेंगे. So you have to start in a systematic manner. So what we do is, as we enter, first thing we touch, if we go posterior, first thing we touch is the coccyx. Coccyx, and then we go a little higher, and the sacrococcygeal joint comes. Okay. Yeah, sacrococcygeal joint comes. So you have to see whether it's generally it's mobile. But if she had some history of injury, you should be very particular to see this joint, because it may be then fibrous. Then it's going to be difficult, that because coccyx is pointing inwards, and then the epidiameter of the outlet will decrease. But most of the times it's quite flexible. So it's the obstetrical outlet from where we start. So we start from the sacral tip and we try to go up and we try to feel for the sacral curve. So it should be going like this. And we try to reach the sacral promontory. So this is what it is. But in a normal pelvis and a woman with the fetus inside, we cannot see. My fingers cannot reach in a gynecoid type of a pelvis with good diameters. I can't reach the sacral promontory. So that will tell me about little bit about the curve of the sacrum as well as the sacral promontory. So we try to reach there. And if somebody can reach there, then you have to take your hand up and measure the diameter. Of course, afterwards, you just have to mark it there in your finger. And after that, you try to go towards the sides and try to feel the cavity, the sacrosciatic notch, which should be wide enough, the sacral ischial spines, and similarly on the other side, sacrosciatic notch and the ischial spine, which will tell you about the mid cavity and the plane of least dimension. And you should be try to reach both the ischial spines together, which is very difficult in a live woman, but reaching the 2 ischial spines at the same plane. You know? So anyway, this will tell you about the interspinous diameter. So as we are coming out, we feel for this ischial porosity from inside, and then we go to the subpubic angle, which should be admitting about 3 fingers, should be wide enough. This narrow, then you have to see how your 2 fingers are. Then take out your fingers and you can measure this angle by keeping these 2 fingers here. Okay, 85 degree. That's what the normal is. And once you've done that, You have to feel for the ischial on the two sides and your knuckles. Average hand, 4 knuckles. Bigger hand you should be knowing than your hand's diameter. I've already told you. So this is what should be here. This is approximately at the level of the anus. Okay, so this is where you have to find out. So this will tell you about the pelvic assessment. This is clinical pelvimetry. If you have a doubt, earlier they used to do X-ray pelvimetry. Nowadays it's out because too much of radiation is there. Then to the mother, mainly to the fetus. That's where this thing. So these days we don't do X-ray pelvimetry. Ultrasound generally we do otherwise also, so we know the fetal head diameters. And in relation to the pelvis, the best is MRI pelvimetry if you have a doubt, but of course this is not done routinely. But some institutions where you have a doubt, where you want to do a trial of labor and it's freely available, and the radiologist is well versed with doing MRI pelvimetry, then it can be done. I'll just show you some pictures. See, this is the sagittal midline MRI. Fetus is in the vertex presentation. Now this is giving me the AP diameter of the pelvis, starting from the sacral promontory till the upper border of the symphysis. So that distance can be measured. Similarly, from the sacral tip to the lower border of symphysis pubis will give me the outlet diameter. And it is also showing me that fetal head has not engaged. It's still above the pelvic rim. So little dipping is there, but still above the pelvic rim. So this is the bladder and the rectum posteriorly. And this is the vagina. The arrow is showing the vagina below. This is the vagina, the cervix. Okay. So this is sagittal view, the sagittal or midline MRI. We can have transverse MRI also at the pelvic inlet. So between the two iliopectineal eminences, that will give me the transverse diameter here. At the it is measured at the widest point. At the level of cervix, almost it comes. So this is little lower in the pelvis, mid pelvis. Measurement of transverse bispinous or mid pelvic diameter. So this different views, we keep on taking sections, and we have this different views, and then we can chart it and we can find out the diameters. So accordingly, then we decide whether there is any CPD or not. So this is very accurate method, but still not available uniformly everywhere. So this is what the diameters are. Just a line drawn over that: inlet, mid cavity, and outlet. So this is how we do. Then after we have done that pelvic assessment, we have to do to rule out CPD also. Contracted pelvis, I think this is beyond this chapter, today's class. So when we are doing this thing, we keep our finger on the level of the ischial spine. We try to push the head, and this goes at the symphysis pubis, like this. This is your finger. This is the thumb, and tries to push the head down. That if head goes, that's at the onset of labor, is in fact we are able to rule out CPD best. So then if head is going in, not touching your thumb, then it is no CPD. It just juts here, it's mild degree. And if it is overhanging, the head is overhanging over it, then it is a major degree. Similarly, per abdomen method, we keep these two fingers here, again trying to push the head down. So inside, same level, or outside, overlapping. Then it is mild, moderate, severe. And accordingly, we decide what is to be done. So I think that's all for today. Thank you. Anything you want to ask?
That's great, madam.
Thank you, Dr.
It was,
Mala.
it was really great.
I hope they could understand.
Students, if you,
Online
if you have
telling
any
is very
doubt,
difficult.
please ask madam. Madam always takes our classes in Gurukul.
Yeah, it's physically it's easier to explain the pelvis rather than these
I know,
pictures.
madam. किसी को कोई डाउट नहीं है?
pelvis सबको आता है. Somebody has written, Madam, please repeat the outlet measurements. See, outlet measurements I have already told, anatomical and obstetrical outlet. Anatomical is AP diameter from the lower border of the symphysis pubis till the coccyx. 13 centimeters, 12 centimeters, and in the least pelvic dimension, it is from here to the sacral tape and the ischial spines. So this is 10.5 centimeters. It becomes less. So that's what it is between the two. So the least dimension you should be remembering, because that is the area from where the fetus has to cross before coming on to the final obstetric out. Finally out. So that's what it is.
Any other doubts you all have? There's nothing in the chat box that I can see.
Yeah, nothing except that outlet part.
Hmm.
So nothing is there in that. So I'll just show this diameters which they were talking about the outlet. Yeah. 13 centimeters, 11 centimeters. Posterior sagittal is 8.5 centimeter at level of osteotuberosity. Anatomical outlet from the tip of the coccyx. Okay, then I stop sharing.
Yes, ma'am.
Should I?
Ma'am, it's always a pleasure to have you as teacher.
Thank you.
Your classes are really very great. And I'm sure all the students have lightly benefited from your class, ma'am.
I hope
What
so.
subject the students want? Your choice for next class? Any suggestion? You can write in the chat box if you want any particular class. Otherwise, we'll keep the class of our choice. We'll have the next class in the first week of November, because next month, this October month is full of festivals.
Yeah.
And we will suggest the topic very soon.
Yeah.
Okay, ma'am. Bye-bye. Good night.
Thank you very much. Bye. Good night.
Thank you so much, ma'am. Thank you so much.
Thank you, ma'am.
Physiological changes. Somebody has written in pregnancy. Somebody has written physiological changes in pregnancy. So we will have the next class on physiological changes in pregnancy. And a date I will declare most probably in the first week of November. Okay.